Great. So this is yet another controversial question. And in fact, to me, that's underscored by the fact that Karen and I are largely looking at the same data set and saying, here you should not do NGS. And I'm here saying, yeah, you should do NGS. And we'll talk about why it's really a gray area, but I'll try to point out the argument in favor. I know that many of you get cranky if you don't see a pie chart of mutations every 5 minutes. And so I did want to put this up there to appease everybody that, yes, I've got one too. It's okay. But I would point out just the number of mutations that are here. And, what we've seen as time goes on is that the number of slices in that pie is increasing every year. And it's not just the numbers or the actual slices, but what we've also seen is a conversion of several of these as time goes by from a fanciful potential target to a real life useful target that translates to survival benefits that are really quite meaningful. And I think it's going to be instructive as we move forward to think about ROS1, because ROS1 is kind of in the midst of it. And I think looking at where it's been and where it's going is an important question, because where ROS1 goes, so are others. So I would say there are certain situations in which a la carte testing is preferable, and others where broad panel testing is preferable. If you have only one or a few relevant tests, it makes sense to just do an a la carte approach. I would also say that if cost of one is just a small fraction of the total panel cost, that makes sense. And if you have DNA from the tumor readily available, that makes sense to do one-off testing. On the other hand, I would argue that our current situation is more concordant with the situation of multiple relevant tests, or at least potentially an emerging relevant tests. The cost, once you get past a few, is approaching and often exceeding the cost of the total panel, and that we have limited access to tumor DNA. So this is really just a variation, again, on the same table that Karen showed, that we have several targets. I would agree that EGFR and ALK are the most ironclad in 2015, but ROS1 has come a long way in a short time. And there's a reason that Karen had it in parenthesis. Many of us would have major misgivings about not testing for ROS1, and several of us probably have at least one or a few patients with a ROS1 mutation who are doing remarkably well on crizotinib, and it's hard to think about how we would consign them to a lot less favorable outcome if we didn't test for it. There are others that are just a half step behind, and certainly BRAF is among them. HER2 is a potentially very attractive target. We've got MET amplification and RET rearrangements, and these are all listed now in the NCCN guidelines as evidence-based choices. And the reason they're in the NCCN guidelines is to encourage consideration of them as potentially relevant, actionable targets. Now, I'd also make the point, and I really do think that Karen raised an excellent point, that one of the challenges is something being called actionable is not the same thing as actionable. I mean, that just having some fanciful thing that worked in a rat once doesn't mean that that is an effective therapy. And none of these is something that is just based on preclinical data and a theory that it might work. These are based on clinical data, and it may be still small numbers of patients, but when you've got waterfall plots like the ones I'll show, that is a different situation than just something in Foundation One's report saying everolimus might work here, just saying, So I don't think that's helpful, and I think that we should hold agents to a higher standard than just wild speculation that something could work and I've run out of good ideas. But let's look at ROS1, and the story only trickled out a few years ago of some patients doing extremely well with it, and a JCO publication in 2012, and there was no waterfall plot at that time. There was just a before and after, and a story that some of these patients were tested, found to have a ROS1 rearrangement, and were doing extremely well on it. And a few years later, we've got Alice's New England Journal paper with 50 patients and a waterfall plot that is astounding, is exactly what we would hope to see with a target. But even that is not at this time an FDA-approved agent. It has breakthrough designation, but I think few of us would quibble that we would not be encouraged and enthused about giving crizotinib in someone with a ROS1 rearrangement based on that waterfall plot. But when is the right time? I mean, this is really a continuum from very promising translation from an early story and a few clinical cases to an absolute truism that you would not want to miss the opportunity. These patients with a ROS1 rearrangement tend to have responses that last longer than the crizotinib responses in ALK. And everyone started with this idea that we definitely want to give crizotinib to our ALK patients. My concern overall is that, like the aphorism from the House of God, you can't find a fever if you don't take a temperature. You could really say the same thing about a lot of these targeted therapies or potentially valuable targets. So let's look at some of the more contemporary ones. I mean, you've got RET, and this is one that is not yet a reflex for everyone to think about, but this is a pretty promising waterfall plot with a response rate in excess of 40%. And this is, I would say, something that just predates more evidence that we will need as time goes by. Here is a before and after that's not really that qualitatively different from the early ROS1 story in 2012. And, the question is really, how many patients would you be comfortable missing between that early kind of report, a very promising waterfall plot, and the years of further testing to make it an ironclad indication. The other point I'd make, or one other point, is the cost issue, and cost is always becoming more of an issue, but I would say that it's not that clearly compelling to do a la carte testing if you're going to do multiple tests. I practice in Seattle, where there is a disproportionate amount of never smoking Asian patients, but that's still not the majority of my patients, and certainly in North America, that's not the prevailing approach, where we should expect that more than half of our patients will have an EGFR or ALK rearrangement. And the majority of patients, you're going to go further potentially down that route. And it does not take more than 4 or 5 a la carte tests before you are approaching the range of NGS testing that is today, let alone as prices are dropping. And certainly that's the direction that things should be going as the field becomes more competitive. I agree with Karen that it's really hard to get precise data on costs because I've asked even my own lab, and all I get is evasive glances and people looking at their shoes. So that's a good reason why it's you've got these ranges here, because you get the feeling it's like, well, how much you got, So So we'll see. But I think it's only going to get better as there is more pressure on the system. The other issue is tissue. Now, we are talking about lung cancer, which is not the most accessible tumor. I had the good fortune in the first case I had presented about somebody who had a supraclavicular node just waiting there, but that's not the majority of my patients. And in the clear majority of patients, we have to go looking a little harder. And what I'm showing here is a pneumothorax. And I have visited a patient this week in one of my patients who had a repeat biopsy for purposes of pursuing T790M testing, who ended up with a chest tube in the hospital for a couple of days. And that's not a rare situation, and it adds a lot of cost as well. So the idea is that each of these serial tests takes more tissue than just doing it once. In addition, there's also the issue of the time factor. Now, fortunately, I think just like the cost issues, as we move to high-seq and the evolution of the field, it's going to be increasingly possible to get these data within 2 weeks or 7 to 10 days even. But right now it takes longer. And it's a real potential challenge of having to look for this issue after doing a repeat biopsy in the third line setting. Now, it is true that, yes, we talk about the value of repeat biopsies, but that's a different situation of having a patient for whom you already have an identified driver mutation. If you have a potentially up-and-coming driver mutation, that was present from the beginning, and it would be relevant to find this early on, and then have it when you need it. I mean, even, I would argue, finding something in 2015 that maybe becomes an actionable result at ASCO 2016 is a valuable finding. But it's going to be a challenge to have to repeat a biopsy because you exhausted all the tissue on 4 or 5 consecutive a la carte tests at the time of initial diagnosis, and then there was something that was number 7 on the list that didn't make the cut. I would argue as well that in addition to the ones that are more established, really everything other than immunotherapy that has been exciting to think and talk about in lung cancer over the last decade has been related to targeted therapies. I mean, we can go on for a long time talking about EGFR and ALK, but we're talking about still 15% of the North American population. We are going to be chipping away at lung cancer in 2% increments for the next several years. And even ROS1, which is a 1% population that we might have years ago thought was just impossible, infeasible to identify and target, is now one that many, if not most of us, would consider extremely desirable to test for and act upon. So the point is, you can find a lot more 1 and 2% by doing blanket testing, and this is going to lead to a wide range of patients going on clinical trials and accelerating the rate of research. We're going to find the BRAF mutations, the MET amplifications, and ideally, they can go on clinical trials at your center or in your area and actually lead to definitive answers to these questions rather than just speculation based on 10 people in a waterfall plot. So we need larger numbers, and that is attainable if, as Alice mentioned, yes, 4% of ALK of patients having an ALK rearrangement seems small, but 4% of a large number is still a healthy number. And I'd say the same thing about the 1 and 2 and 3% populations. If we can identify these patients in a high yield and direct them to studies, we're really going to accelerate the rate of our understanding of this field and identifying the new targets that we've picked up, like ROS1. I mean, we're all impressed by the rate at which we've learned about ALK and ROS, certainly EGFR, but the pace has been fast over the last few years, and I think none of us would expect or hope that we've exhausted the list right now. Many of those that are on the table that both Karen and I showed are going to be more actionable with more evidence in the next few years. But it's going to happen a lot faster if we're actually identifying most of these prospectively. So my conclusion is that we should default to NGS testing because we have not one or two, but more than 5 actionable targets that are not just actionable in terms of I have a drug that we could try, but that have response rates in the 30, 40, 50% or higher range. And that many of these are just not going to be identified if you don't look for them. As the number of these is going to be increasing as we direct patients to the appropriate clinical trials, as the trials that are being done are getting completed. And the cost effectiveness and the turnaround time of NGS testing is only going to be improving as time goes on. At the same time, tissue is in limited supply. It will always be a challenge. And that is the most efficient way to use the tissue available is to do broad testing for the things that are most useful targets now and likely or potentially attractive targets that we aren't necessarily thinking about yet. But if history has shown us anything, it's that we can expect to see others in the next 1 or 2 years as these patients continue to be followed. And this is accelerating the rate of research that's really reinvigorated the field of lung cancer, and I think it's only going to continue. Thanks very much.